Hey guys, I'm here with Alexis
Yeah.
Léveillé, aka Nobullshitphysio. Today we're going to talk a little bit about injuries and common physiotherapy myths. So before we get into some questions, do you just want to give a brief introduction of yourself?
Yeah, sure. My name's Alexis Léveillé, as you said. I'm a physical therapist. I work in Montreal, Canada, in the French portion. I got my master's from McGill in physical therapy and also did my undergrad there also in physical therapy. And I provide like international pain coaching to people, just mostly like one or three visits, just for it's mostly like third or fourth or fifth opinions, people that been dragged around and want to know what to do with it and how to manage it long term. But I also get like short consults. And my page, I guess that's how most people know me, is a lot of like myth busting and also a lot of shit posting, I'd say. I like to make fun of stupid ideas. I started off doing making fun of charlatans, but that's also not good. And also my professional board doesn't like it. So I'm more making fun of ideas now when I can. And yeah, I don't know. I basically talk about what interests me in the areas of fitness. Right now, I'm doing like a huge deep dive on how urban planning is like affecting your health. And the rabbit hole goes really deep. Health is deeply political. Like people that don't believe this and they get mad whenever I post something political. I believe it's kind of like an ostrich, planting their head in the sand. Like it is political whether you like it or not. But my page is not really political. It's about health, which happens to be political. Yeah.
So to start with, could you outline how injuries occur? So I think one thing that we see on social media a lot is you have back pain because you have tight hips and weak glutes. You have knee pain because your VMO isn't firing correctly. So I'd like to just
Yeah.
dispel a lot of these myths. And if you can paint with broad strokes, why do we get injured? Why do we get pain?
I'd say like if we look at like injury versus pain, we first have to like differentiate the two. Like getting an injury, I think a big part is just bad luck. Like sometimes shit happens. Like there's a pebble on the field and you twist your ankle, and there's not much we can do about this. This is why like a lot of literature, let's say on ACLs, makes a difference. They only look at like let's say non-contact injuries. Because no matter how much training you can do, there's nothing you can do if like a dude is like, yeah, I'm gonna injure that guy.
Yeah.
In a sport where you're not supposed to do that, right? It might be different in boxing. Um, it's also why you don't look at boxing injuries with like non-contact injuries in boxing, or there's not a lot of research there. But yeah, I'd say if we look like first at like injuries, I'd say it's a lot of it. If we have to summarize it in like one sentence, it's like a lack of preparation mixed with rapid increases of load. So you're basically doing too much too soon. That can explain it as well, like pain that happens gradually, like what we'd call like sports related overuse injuries, like a lot of like tendinopathy and stuff like that. Um, we can say that strength is probably a causal factor, like a lack of strength, because I believe it's the Bo Larson study from 2015 showed that like with strength training strategies, not even that hard, just like gentle strength training pretty much. And especially in soccer players, it was pretty useful. I think it was 50 to 66% reduction in injuries, depending on if you're looking at those, again, overuse injuries or those traumatic injuries. And yeah, so strength training did that even in small doses. So we don't know if strength is the causal variable or if it's preparation. So the action of actually doing strength training prepares your tissue in some other ways. That is not related to strength. So some examples could be if you look at like tendons, if you train over like 2 weeks doing like jump rope and stuff like that, your tendons get stiffer before hypertrophy happens. So that could also be something that's happening. I don't think it's the only effect because if you look at who benefits from them most, it's people who generally do not engage in strength training as much. So the most effective population is usually, first of all, women who typically have been discouraged in participating in strength training because, like, oh, you're going to get too bulky, blah, 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 or, they're discouraged from doing sports in the first place. So it's like, usually it's more elite people that do strength training and also soccer athletes, which, I've been a soccer player my whole life pretty much. I played in university as well. I was like on the varsity team and at McGill. And you'll notice like I was one of the strongest players on the team and I'm not even that strong. Um, wasn't that good either. But the point is, soccer player is like very low hanging fruit. So it's probably that like let's say you have a power lifter It's
Yep.
probably not because he's weak, unless he's like a beginner. It's probably just because his load is way overboard. Um, we also know again that load is probably a big factor, both in terms of magnitude and in terms of like increases, like rapid increases. Um, I guess the easiest way to talk about increases is there's acute to work chronic to workload ratio. So it's basically looking at what you're usually doing, the chronic workload, and then comparing that to the acute workload. So let's say usually you're running, let's take something easy like jogging. Let's say you're jogging 50 kilometers at an average pace of, let's say um, let's say like 5 minutes, 5 minutes to a kilometer.
Yep.
That's your usual pace. And then you either increase the speed dramatically or you increase the dosage dramatically, then technically your range of injury goes way up. Problem with this is we know that it matters. It's just hard to find a specific number because it seems to vary population to population. We don't have enough data yet to kind of predict it. This is mostly based on the work of, I believe, like Ting Gabbett. And he started in rugby players, I believe. And in that population, it might be relevant. So what they would do, they would have people trained, they would time the training and ask them to rate them like on a scale of 0 to 10, like how intense was that workout? What we call like arbitrary units, essentially. And then you calculate like a workload ratio, and then you look, oh, when people spike their training, let's say they had like 2 games in the same week or something, the injuries went up. The magic number you used, what I believe was like a 30% increase, is when it was like injuries went like skyrocketed. So it was like, let's try to keep it below that increase, like below a 30% increase within the month. But the problem is that it hasn't been replicated in other population. And there's this guy, Franco Bellizzeri from Australia, actually. I think he's originally Italian, but he teaches in Australia. And he basically took all the studies and analyzed the model differently. And he said that, yeah, the effect kind of disappears. So we need more research. We just know enough by now to know that it matters for injury. We just don't know how to influence it to make an effective difference or not. We just know that reducing it probably helps. We just don't know how much and in which populations. So that's why when you see like this whole debate about load management in the NBA, I don't know if you're an NBA fan.
Yep.
Yeah, so a lot of like, especially the old heads, will complain about the like load management. There's like, oh, players are such like pussies or something. Like why are they resting? Why are they doing this? And it's like, yeah, there is some data to show it. Is it a science? I don't think so. And there's a lot of, as you probably know, there's a lot of pseudoscience in uh like elite sports. So I think a
Yeah.
lot of it is like people act like, yeah, if we don't do this, he's gonna get injured. We can't say that right now. We just know that probably when someone's really tired, it's probably a good time to rest them. We do have data on this. I can talk about the Watson paper from 2019, which shows that like soreness and sleep seem to be independent predictors of injury.
Yep.
Um, yeah, even when you account for other variables. So they looked at people's, it was a small study though, but it was like high level athletes, so collegiate basketball players, 19 players, there was 32 injuries in total. And they show that if people had like decreased sleep or increased soreness like the day before, essentially, they have a way bigger risk of injuries. And it could be a small difference, like even an hour. There's other studies that replicated that, like during exam seasons, injuries were higher and stress is higher and sleep is worse. And I believe there's a third paper where they artificially added 1 hour in one group and then reduced 1 hour in the other or something like that. And also found the same results. So sleep is also a major factor. But again, it comes down to how prepared are you, how rested and recuperated are you from your previous bout of physical exercise. I guess that kind of covers it for acute injuries. If we're talking about more like um, chronic injuries, I'd say it's a bit different. Like it's I'd say it's not as clear cut because there's so many
So many
factors.
potential
But yeah,
contributing factors. Yeah. I think
uh,
I think a good take-home message here is that you can't reduce it to a single thing like your glutes are tight or your quads are weak, and that it is multifactorial.
that's a good point.
To go back to your point about preparation is very important, and if you increase stress through your tissues acutely, it increases your risk of injury. Would you say that preparation is more important than technique when it comes to injuries?
Um, I'll say like a lot of like when I have a lot of posts on my page, I say technique. Well, what people get out of it is that technique's not important. That's not the point. So technique's important for hypertrophy and whatever you're doing. And if you're an athlete, you know technique's important in doing the task well. Does it prepare injury? It doesn't seem like it, because it seems like humans are there. We've evolved to move a bunch of different ways,
Yep.
right? So when we come out of the womb, we don't really know what we're going to be doing. We don't know if we're going to be hunters or gatherers or sedentary. So body's like, okay, we'll just make a guy that can adapt. I'd say that's probably what humans are best at, actually. Um, so technique, I don't think predicts injury in and of itself, but it can be a modulator of load. So if you think about just an example, it could be like running and walking essentially are the same activity. It's just not the same technique. You could argue that, right? So
Yep.
it's a spectrum of how it modulates load. So let's say you do a deadlift that's more flexed. It's not that it's always bad and you should never do that. Like sometimes I prescribe Jefferson curls. I used to do some for myself. It's more that it might take more time to adapt for a back because it's probably higher load on the back based on at least cadaver studies that we have. It depends. Like it's really specific and case dependent. Like some for some reason stooping, which is like a slouch squat, technically puts less stress on the back when you're picking up a light object than doing it the way we're taught in like those principles of safe movement teach us how to do. Look like the straight back, avoid the butt wink or whatever, lift with your legs. Technically, that puts more stress on the back in live humans for some reason.
That also depends where you measure it, right? Like if you measure it at L4, L5 versus L5, S1, you might see a different shearing stress in different studies. So I don't think it's
Yeah.
as simple as that, that this is less stressful on the back and that's more stressful on the back. But yeah, I
Yeah.
grant your point.
Yeah, that's a good point. Also, it kind of ties into my next point that it's, if you're lifting an object, if you're lifting yourself, it, it usually doesn't make a dent in terms of total number of injuries because the load is the same. You weigh the same each step, whether you're running on your tiptoes or you're running on your heels. It's just you're modulating where the load is applied. So I won't correct someone's running form unless it's for performance reasons and they have a preference or they want to try or they're like, hey, I always get injured below the ankle. Then I'm like, okay, we could probably try like thicker shoes and running on your heels more. Um, but if it's just something like, correcting, first of all, how people run is kind of hard. So if I don't have to do that, I'll probably won't. And usually people don't like it and might affect performance for the worst too. Usually people are good at, solving a motor problem and picking up the running form that's the best for them, as long as they have like, some form of general guidance. Um, at least for like simple tasks like running. So, point is, technique again doesn't seem to make a dent in overall injuries, but it could make a difference in terms of like specific injuries. So, like, let's say you always get injured. Let's take running again. You always get injured below the ankle. It probably might play a role that you're always running on the tiptoes, like you're doing an anti-your foot strike. It doesn't mean it's bad. It's just it takes more time to recuperate from that because you concentrate more of the load of running, like the ground reaction force, more of them go below the ankle instead of your knee and your hip. And conversely, if you run more on your heels, more stress is going to go on your knee and your hip. So technique might have an effect, but it's a small effect in general. Because again, what's more important is absolute load, because that's what your ligaments absorb. They don't know what's going on. They just know how much load is applied onto them, right?
Yep.
And technique is just a small modifier of that, the modulating variable. Yeah, so if you look at specific injury sites, then yes, technique might have an impact. But again, I think the overarching point is that it doesn't mean it's bad. It's just some techniques take more time to recuperate from at specific joints.
I'm glad you started that with technique is a modulator of stress and that technique is important for hypertrophy and can influence injury. Because I see a lot of criticisms on your posts and on Adam Meakin's posts where people take it as, oh, technique doesn't matter. And
Yeah.
I don't think that's the point you guys are trying to make. It's saying that things like spinal flexion in the deadlift is normal, spinal flexion in the squat is normal and unavoidable. And you can adapt to it. So don't tell
Yeah.
people that, spinal flexion is going to give you back cancer.
Yeah. And even people that would disagree with that, like where they say, no, it's not a spectrum, like spinal flexion is always bad.
Yep.
Well, you're always flexing your back anyways when you deadlift, whether you see it or not. There's like countless studies that show that it's inevitable. Like it's unavoidable if the lift is being lifted from the ground to bend your spine, even though you're not seeing it visually. And if you look at running, like every technique is going to be way different, even in pro athletes. Like pro athletes tend to have less variation, at least in lifting or throwing. They
Yep.
tend to be better at doing the same thing in the same exact way. And it honestly could participate in why they get injured so much. It's just because they're always stressing the joint the same exact way. Um, could be why sedentary people have more pain as well, besides the like microinflammation portion, like where they're always like kind of stressing their body enough to create stress, but not enough to create adaptations. What we call like low grade chronic inflammation. Um, they're always in the same position, so that could be another like variation of that. But yeah, I guess it's kind of complicated. Is what I want to say. Yeah.
Just to give an example of when you might want to alter your technique for a particular goal. If you think of something like a bicep curl, if your goal is
Yeah.
purely to grow your biceps rather than lift as much weight as possible, you probably don't want to swing. You don't want to arch your back. You want to control the movement as much as possible because you want to fatigue your biceps and you don't want to fatigue muscles elsewhere. You don't want to fatigue your hip extensors by trying to kip the weight up. So it makes perfect sense to use kind of this good form, or at least what most people would perceive as good form in a gym,
Yeah.
for that purpose. But if you're in a squat competition, your goal is to lift as much weight as possible within the parameters of what satisfies that lift. So if your knees
Yeah.
cave in, it's absolutely fine. And I think we have enough world record holders that do that you can show that it is safe and your body can adapt to it. But in the gym, if your goal is to work your quads as much as possible, or your goal is to grow your muscles using a lighter load, then it makes sense to use stricter parameters for what you allow in that lift. So you might not let your knees cave in. You might try to keep a straighter spine. You might try to keep your chest more upright. So it very much depends on your goals.
Yeah. I get behind that. It's a really good point.
Another thing with that is people who criticize, spinal flexion. They say spinal flexion's bad. If you flex your spine in a deadlift, all sorts of bad things are going to happen to you forever. What I always come back to is you can flex your spine with a broomstick. Like most people know that. Most people don't perceive Jefferson curls with broomstick as being some horrible exercise to do. However, if you replace that broomstick with a barbell, all of a sudden people's ideas change and they think this is bad form and it's terrible for you. But if you can do it with a broomstick, you can do it with a barbell and your body can adapt to it. Sure, certain things might adapt slower, but it doesn't mean that it's wrong or that it's inherently dangerous.
Yeah, it's a weird dichotomy. And what's interesting is if you look at the, if I recall, it's the data on like cadavers is extremely complex and dense. But last time I did my really big review on this, and I hope Greg Lehman would correct me on this if I'm wrong. But if I recall, what's interesting about that like distinction that people make is that if you look at ligament tears and like disc prolapse and stuff like that, and you observe in animals that are subjected to these like insane amounts of stress without any protecting gear, and also they're dead,
Yeah,
so they can't adapt to
they
it.
can't adapt.
It
Yep.
tends, yeah, it tends to be that high load will break the bones, like fracture the bone of the vertebra, whereas
Yep.
low load done millions of times, or not millions, but like thousands of times, um, will be more the disc. So it's kind of this contradiction because they're always talking about the disc, and it seems like they're like, no, no, you can bend with your back, that's fine. Just don't add high loads. But if you look at like elite lifters that lift incredible amounts of loads, it's never the fractured vertebra
Yeah.
because the
Yeah.
bone
Yeah.
adapts, right?
Yeah. Yeah. And your disc
And if you
adapts
look,
too.
yeah, and I forgot the author. It's some Japanese name. It was like Shiro or something. Um, did a paper on this in 2010. It's the Surrey paper from 2010, I'm pretty sure. Um, and what they showed is that, like, if you ask people that have diagnosed, confirmed disc hernias, like with, leg pain and all that, in 90, like almost like 90% of cases, they don't really know what caused it initially,
Yeah.
like in the vast majority of cases. So it's like a weird selective skepticism, I guess. And they also claim that the disc doesn't adapt. And this claim, like I made a big post about this back when Squat U published this paper with Andrew Locke and
Yep.
the
Yep.
Squad Doctor or whatever. And it was so interesting because they would say like, um, there's evidence that the disc adapts, but it's not the annulus fibrosis, which is the part that ruptures, like the rim around the disc that ruptures when you get a hernia, where it pops at like the nucleus, the soft jelly, I guess. It's not really soft jelly, but that's the image that they use, like juts out of the the disc. But that's such a weird argument because it's like, yeah, the first of all, like the annulus fibrosus is more vascular than the nucleus. So that it's like, why are you saying that it's fine for the nucleus to do this if it literally has no, there's pretty much no blood flow there. But the annulus is like, I believe it's like 30% vascularized or something. Less as you age, but it is still, there's still blood flow there. So you can't say no, there's no blood flow, it doesn't adapt, and then say, but the middle adapts even though there's zero blood flow. That first of all, that doesn't make sense at face value. And
Yep.
after that, the papers that they cited, they said no, the changes in hydration or the changes in structure that we see, which was done with the GAG set. It's a very specific type of MRI, which can be a measure of like structure and hydration. So the GAG, I don't remember what it stands for exactly, something like, you know what, I'd have to look it up, but maybe you look it up, Simon.
Yep.
But yeah, so the point is it's a measure of structure because you could where structure is, the water goes essentially. So with that, they can estimate how structure is improving in the disc. And there's a bunch of papers showing that, like this paper done in rowing, I forgot what it's called. Hang on, the flexion rower disc adaptation. Because it's a Franken paper. Yeah, Franken 2022 paper. They show that the GAC test measures were better in people that do very high load flexion all the time, so elite rowers.
Yep.
And it was bigger within season. So basically, when they were doing more flexion at high loads, like basically going all the way, then pulling, that's what a rowing movement is.
Yep.
Their disc structure improved. They had bigger, thicker discs.
Yeah.
And that kind of went away as they stopped doing it, interestingly enough. So it's the only prospective paper we have on this. And they said no, because the gag doesn't go to the annulus, it's only the nucleus. But all the papers we have on this show the opposite. It's very strange.
Yeah,
Um,
those guys also don't believe in non-specific low back pain, which is
yeah,
basically the experts' consensus. So I don't know. I don't know if those guys are the trustiest of resources. And to go back to your point about using cadaver studies, we should be very careful to draw conclusions to living humans from cadaver studies because basically every tissue will break down with repetitive stress. So if you take the
yeah,
example, if you just replicated the stress of walking on your bones and
hmm
you did that to dead bones, they will break. They'll break very
yeah,
quickly. But we all know that we can walk basically our whole lives and be fine.
yeah,
So, and it's actually a very healthy thing to do. So I
yeah.
think we need to be very careful with, drawing conclusions that this is bad for your back because when we flex a pig spine 1,000 times under this load, it breaks down. Well, it's a dead pig spine.
Like strength training is useless because like if I when I flex this bicep a million times, there was no gain in bicep strength.
That's it. And your tendon ruptures if it's a dead tendon. So
Yeah.
yeah, you shouldn't bicep curl. On this note of back pain, one of the most common things you'll see on social media is your back hurts because your core is weak. Do you have anything to say on this topic?
I did with my friend Elliot Sierra, who I host my podcast with, the fact check. We did a big live react. It was awful. I think the 3 hour Uberman podcast did on low back pain,
Yeah.
and we were like frantically looking for data. We found one paper. Um, I'd have to pull it up. It was one paper that showed that doing abs, like they basically gave core strengthening to some people,
Yep.
and there seemed to be fewer episode of low back pain. But if I recall. Yeah, it was a paper in 60 people. That's the only paper I could find. It was the Kang-hee Cho 2014 paper, Trunk muscle strength as a risk factor for non-specific low back pain, a pilot study. So a pilot study is not, you're not supposed to make claims with that. It's more to be like, hey, we should look at this
Proof of
with an
concept.
actual paper. Because first of all, um, oh no, that's a different paper. But essentially, well, this one showed that it didn't, like flexor weakness didn't predict the incidence of low back pain. So
Yep.
there's that. There's another paper. I don't recall which one. I think it was in the military. But they did essentially like bicep, if not bicep, but it essentially did like core strengthening, and they showed less pain incidence, if I recall.
Yep.
But not less pain. It's I don't think we can make good claims there because that's based on one claim. The whole craze about trunk fitness, I think, started with one, I believe it was like a Russian paper where there was like a few millisecond, I think it was 30 millisecond delay in the activation of the deep core compared to the outer core of the
Yep.
body. And first of all, it's very hard to replicate. Second, who cares? Like,
Yeah. And
like
and and also this also ties into a similar thing with the knee with the VMO. But just
yeah,
because somebody has this change doesn't mean it was the cause of their pain. So like a
yeah,
great example is you're sure if you have knee pain or if you have back pain, perhaps you have slightly delayed activation of your TA or of your VMO. But if you hit my knee with a hammer, I'm going to have very
yeah,
different motor activation patterns than I did before you hit my knee with a hammer. And these changes did not cause did not cause the injury. You know, it was the hammer that caused the
yeah,
injury. And I would say that a lot of these changes are probably a good thing and are probably protected. So like if
yeah,
you hit my knee with a hammer, I'm almost certain that my activation, my EMG readings of my quads, my hamstrings, my calves would probably go down.
yeah,
And that's probably protective because by using those muscles, I'm going to be putting more force on my knee. I'm going to potentially be delaying healing. So
yeah.
I think
That's
we need to be
probably what it is.
very,
Yeah,
yeah, very careful with drawing conclusions that oh your TA
yeah,
is delayed, therefore we need to change it. Perhaps you don't need to change it. Perhaps you
yeah. And
shouldn't.
this is why one of my biggest issues with like Stuart McGill, he's extremely smart. If you read his paper, it's like incredible the amount of knowledge he has. But this is why I say he's a great technician. Like he has extreme technical knowledge, and he has a background in engineering, so it kind of makes sense.
Yep.
But it's just when he gets to the conclusion or the interpretation of his own results, it's it's just like
Yeah, that's
mind-bogglingly wrong. Like
yeah.
there's one video of him where he's like, yeah, if you like your glute med is not firing, that's what causes like knee OA because I know this because we had a paper where we gave people I believe it was like distraction injections in the hip. So
Yep.
essentially they inject a lot of water or isotonic liquid. So like I believe it was like 0.7 millimoles of whatever NaCl in the knee or whatever it is. And they're like, yeah, people would walk and their glute med would not fire anymore after that. The injection is super painful.
Yep.
And he's like, you see these people when they're in pain, they don't use their glute. It's like, yeah, because they're in pain, they're not using it because it hurts to recruit the muscle that puts stress on the joint that's currently swollen because you made it swollen.
Yeah.
And he's like, no, it shows that it causes knee OA. It's like, no, it doesn't. Like, what are you talking about?
Yeah.
And it's like these mind-boggling, like it doesn't make sense because he's so smart, but then he kind of fumbles at the end.
Yeah.
Uh,
Yeah.
I just don't understand it.
Yeah. Go back to like just go back to that example of, you know, hitting my knee with a hammer. If you test my quad
Yeah,
strength before and after that, I will be vastly weaker afterwards. And it doesn't mean that this weakness caused my injury or that this weakness caused you to hit me with a hammer. Just to come back to what we were talking about earlier. So we spoke a little bit about core weakness as a potential risk factor for back pain, and it doesn't seem to play a large role. Do you have any insights on whether or not there is a best exercise for back pain? Because you often see online somebody has back pain, do these 5 exercises. What do you have to say about those posts?
Um, I say it's kind of reductionist. First of all, low back pain is multifactorial. Different people have different types of low back pain, and it's easy to find a solution given like most low back pain goes away like on its own. So,
Yep.
especially if you've been looking for a while, at one point you're gonna find something. Chronic low back pain is different, and I'd say different people will experience different type of relief. That's why there's kind of a washout effect. If you look at I believe it's Hayden did two meta-analyses. One was a network meta-analysis of like 250 RCTs or so. And it showed that pretty much every exercise provided similar results in terms of low back pain. So it had like a small effect on pain. They found that like McKenzie approach was a little bit better and Pilates was a little bit better. But when you adjust it for other factors like dosage,
Yep.
McKenzie, the effect wasn't better than other approaches. So it's likely that both of these are just something that when you do it, it's like a safe way to move in high dosages in ways that are comfortable or tolerable. McKenzie, if people are not familiar, basically we find a movement that feels good. We tell you to avoid the rest. If I had to simplify, it's way more complicated, but that's like the basic of it. And Pilates is usually sticking to the middle. So you are still active. You're still maybe fighting microinflammation or inflammation, by being active. You get confident. Like there's a lot of non-specific effects of exercise. It does make you feel good, which are all things that, low back pain is really multifactorial. So being active in general is good, and Pilates is a way that you can tolerate when you're in a low back pain, and it's a way that's very tolerable, and it looks safe. Like, people who are afraid of the gym room, they go to Pilates. I'm not saying it's not hard. It's just most people would be like, yeah, that's something you can do that's safe. Often you're on the floor. Like, so I believe it's just a good way, a good effective way to stay um in movement when you're in pain. I don't think it's because there's a magic effect of the core preventing these things. And if you look at like the McGill approach, I believe it was Mélanie Laurent had a paper on this. There's a Cochrane or so systematic review of like the basically the 4 or 5 RCTs that have been done on the McGill approach, which is very similar to Pilates, or has a very similar narrative that you're stabilizing, and it showed that it's not better than any other approach.
Yep.
So yeah, and these are the types of people that claim like, oh, wait, we can pinpoint like the type of pain, like our approach is better. Me in general, I say like I don't get better results than other people. I'll just probably take fewer visits because I'm in general, I think more conscious of the prognosis and the fact that, you just need to keep the patient active or do tolerable thing. Might be different for chronic low back pain. People who've had pain for a while probably need a little bit more hand holding to figure out what's best for them and patterns. I'd say like you kind of have more of the role of a psychologist at that point, like, more
Yeah.
like a coach, I guess.
I agree,
Mix
but
of both.
I think the evidence in both cases doesn't point to one particular best exercise or that core stabilization outperforms general exercise.
Yeah. And these people will usually rebut by saying, oh, well, it's because these all treat non-specific low back pain as one thing, and whereas it's specific different things, so they get non-specific results, which is a fair point. I think Mark Laslett is one of the biggest proponent of that, but there was there was a systematic review of this that was done, I believe, in 2019. So it's like um this was classification approaches. Hang on, let me type that up. Treatment-based classification system for low back pain. Um, yeah, Tagliaferri 2022. Essentially, it showed that like these approaches are like, okay, we're defining which type of low back pain you have and then providing this recipe, the specific recipe adapted to your specific case. They don't tend to show better results than approaches that are just like, yeah, you have low back pain, that just get you moving.
Yeah.
Um,
Yeah.
so the onus is on them because the data right now doesn't support that statement, in my opinion. Um, so I don't know. I think you have to adapt to the person more than the back pain, if that makes sense. Like
I,
obviously, if someone's never done low back, like powerlifting, I'm not going to get them started doing powerlifting. But most of my powerlifters, what I give them for low back pain is just I adapt their training to this. I make it look a little bit more like bodybuilding, for instance.
yeah,
Um,
I have the same approach, and I agree with you with a lot of people read those studies and said, oh, Pilates outperforms other forms of exercise, therefore we should give everyone with back pain Pilates. But I think
yeah,
people need to keep in mind that when you compare two styles of training, you're not really comparing the generic styles of training. You're comparing this particular program with this particular program. And I'm sure if I gave you a very gentle Pilates program when you're in pain versus a heavy powerlifting program when you're in pain, the gentle one would probably outperform. But that's comparing gentle Pilates to heavy powerlifting, not gentle powerlifting. And I
yeah,
think it's just that Pilates is just a little bit easier to scale and to be gentle with and avoid movements that provoke pain. Um,
yeah,
so yeah, I have the same approach. Just get people moving, find a style of exercise that they enjoy, whether it's walking, powerlifting, breakdancing, soccer. Find a way to
hmm
scale it and just ease them back into movement. A lot of reassurance, and there's no magic exercise that anyone needs to do. No specific multifidus training. I think that's another misconception is that you need to do specific multifidus training. Um, but once again, you don't tend to see core stabilization exercises outperform general exercise.
yeah. It might be different for prevention, so we're still looking for that holy grail. There's still like there's studies showing that being generally active is predictive of like future low back pain to some degree, which is ironic because like physical capacity doesn't seem to be.
Predictive
That's based on other paper.
in which direction? The more physically active you are,
Uh,
the likely you're to get back pain.
no, like if you're generally active, you have less back pain.
Yeah.
Um, but it doesn't have to be like super intense. It's just like even walking at a brisk pace fits. But it's basically like sticking to physical activity guidelines, if I recall. Um, but what's interesting is that physical capacity doesn't. So it's probably just that people who are more capable got more capable by doing more intense activities, which your rate of injury kind of goes up when you do that. So it
Yeah.
probably just cancels out. And you see that with athletes, like they have way more damage on imaging, they have way more stuff, but it's not, they don't have more symptoms, likely because their body just adapted to it, if that makes
Yeah.
sense. Um, but yeah, if we're talking about also about prevention, we're still looking for that. The only paper that I could find, and that's just like the only thing I'll usually give for like prevention of low back pain, is just some low back strengthening once they're out of the woods, like their pain is under control, or mostly when it's gone, basically. I'll
Yep.
just tell them like maybe get a strong back because that seems to work. Again, if we go back to that pilot paper, it's terrible data. Again, it's not homogeneous, but if I have to make an educated guess, I'll pick the one that has some data at least. It's again that paper from Kanghi Cho from 2014, probably butchering that name, and showed that basically trunk extensor strength was a predictor for lower incidence of low back pain.
Yeah.
There's a bunch of ways you could do that. You could do 45-degree back extensions. You could do some Superman. Could do some deadlift. Um, it's your pick. But the point is, having these stronger seems to be linked with fewer low back pain. But again, it's a very small sample. It does make seem biologically, though, that in general, if a joint or the muscles surrounding a joint are stronger, they tend to get injured less if you compare other factors. So
Yeah.
who knows?
Mechanistically, that makes sense. The more prepared
Yeah.
you are for something,
Yeah.
the more capacity, the more strength, neuromuscular control, mobility you have, the more resilient your tissues will be compared to somebody who has less of those attributes. So
Mhm.
I agree with you. I think that's a good idea to do some strength training. One thing I want to talk to you about is mobility or flexibility as an attribute to train. So I think when people have specific flexibility or mobility goals, for example, I want to be able to do the splits, it makes sense to stretch. But there's been this kind of argument recently online that stretching isn't really necessary if you're trying to get health benefits from exercise. Do you have any insights on that topic regarding whether or not the general population should stretch? When would you and wouldn't you recommend stretching?
Yeah, I had this conversation with Jeffrey Wolf recently, the Flexible for people who are familiar. Um, the thing is, people will cite this paper that says that flexibility should be retired as a major component of health. I kind of agree to the degree. I think it's a minor component of health because other components like cardiovascular health and muscular strength will predict like mortality, disease, stuff like that. Flexibility won't predict if you're going to get a heart attack or how long you're going to live, right?
Yep.
So I don't think it's a major component. I do think it's useful. It's also very useful for um like athleticism, but in general, like older people, it's not because they can do the splits that like they have a heart. That's good. It probably correlates, but I don't think it's a causal factor.
It's like grip
Um,
strength, huh? Like
yeah, that's it.
people often say you should train your grip strength because it'll make you
Yeah,
live longer. And I disagree with that statement. I think you
yeah,
should train attributes that will help you live longer, like strength training and cardiovascular
yeah.
training. And grip strength is probably a byproduct of just living a healthy, active lifestyle. But I don't think there's any mechanism through which having a stronger grip is going to make you live longer.
Yeah, that's it. So it's like saying like, the amount of bathroom is a good predictor of how expensive a house is. So you just have like a studio with like three bathrooms. I don't think that's gonna help. You know what I
Yeah,
mean?
yeah, yeah.
Um so yeah, if someone is able to do the split at like 70, they're probably doing the other stuff as well, unless they're like a gymnast or someone that's hypermobility. So yeah. Um I will say I do think like the pendulum went a bit too far. Even I think at some point I said like, and if you go back to that paper I cited earlier, that systematic review by Boy Larson, flexibility exercise did not predict injuries at all.
Yep,
If you did it, it didn't prevent injuries. But that's a good point that this account, Flexibility Research, I believe his name is Dan.
yep,
Could be wrong, Dan Van Site.
correct.
He did point out, and that's a really good point, that if you look at injury site, that kind of goes back to that point I said about technique. So if you look at overall injuries, stretching doesn't predict them. Like if you stretch your hamstring, it's not going to predict.
But muscular tendinous
Uh,
injuries, it does.
yeah,
It,
yeah. If you look at the specific muscle that's being stretched, there is some reduction of
yeah.
injury. So like if you look
It's
at like ankle stretching and ankle injuries, there is a small like protective factor of being flexible at the ankle. If
yes.
you're not hypermobile, I believe.
Here's my interpretation of that. If stretching doesn't reduce your overall risk of injury, but it does reduce specific types of injuries, then perhaps it has a positive effect on certain injuries, such as musculotendinous injuries, which makes sense. But it might have a negative effect on other types of injuries, which also makes sense. Because if you increase mobility at a joint, you theoretically decrease stability at a joint. Even if you increase range acutely, you probably have more range accessible that you are not prepared for, which can increase your risk of joint injuries. So, for example, shoulder dislocations, labral tears. But you might reduce your risk of a specific musculotendinous injury of the muscle that you've stretched.
I believe I'm kind of agnostic. I believe it's like we can't say right now based on the current data, but I mean that would make sense. I just don't know if that's true. Yeah, I guess I don't know.
To be
Honestly,
clear, I don't know either. It's
yeah,
just a possibility.
it's I believe it's a really good idea to study that. I'm not gonna lie, but it would be hard to power that research. You need a lot of data to pool.
That's the problem with injury prevention research
Yep,
anyway, is that it's just, shit happens sometimes, and that's the major cause of injury. And it's just very hard to control for all of the other variables that
exactly. Yeah,
that play a role there.
yeah.
So
One reason I'm kind of hesitant is just that, you have this idea when you use a mechanistic approach to injury, there can be some problems. So like, let's say we used to talk a lot about the hamstring to quad ratio.
yep,
That kind of ties into the first question you asked me, like, do imbalances predict injury? And there's this Kelly's 2022 meta-analysis, which shows that none of these variables predict like ACL injury, which if you look at it mechanistically doesn't make sense because the hamstring, if you look at it, is an agonist to the role of the ACL. So it prevents the tibia shifting forward.
yep,
It pulls on the tibia back, right?
yep,
Quad does the opposite. So the logic would be if you have stronger quads, you have more likelihood that your tibia is going to go too far forward, thereby leading to increased rates of ACL injuries. But that's not true at all.
yep.
So it's just like the same way your logic makes sense. I feel like we need data because it's injuries are really complicated. That's my point. Dan, to be fair to Dan doesn't like the flexibility research doesn't believe that. For me, I'm just hesitant. I would definitely not use the term unstable. I would say it's more likely to go further because also we got to remember that flexibility in general is not acquired through changes in neuromuscular structure. It's more like neurological
Is
adaptations, and in most times
Yeah,
there are some rare cases where you can reach longer muscle lengths, but it's over a long period of time with extreme amount of stretching. So it's like you're in pain for like 7 minutes daily for months, or you put someone in a cast for 30 minutes in a really stretched position. Yes, you can change the tissue this way. It's just much easier to reach it when you're actually doing some strength training where you will also change the fascicle length or the pennation angle. So,
yeah.
and these we wouldn't say make you unstable. So I believe this is like maybe a question for a biomechanist. I don't feel qualified to give an answer there.
Yeah, I would agree with that point. However, I think you can even just get rid of that word instability and just say you have more range of motion that you
Yeah,
have.
that's what I would say. Yeah.
I've read a lot about that, and I've heard a lot of people say stretching doesn't change tissues. But I think this is just a kind of ridiculous oversimplification from short-term research. So I used to hear the same thing about strength training, and they used to say resistance training doesn't grow muscle until 3 weeks, or resistance training doesn't grow muscle until 6 weeks. And you see that in textbooks. And I think that was just not having precise enough
Yeah.
measurements of muscle hypertrophy to show it before that. So I'm pretty confident that muscle hypertrophy starts, very quickly, almost immediately, and you might not be able to perceive it for a little while to the naked eye, but if you had good enough measuring devices, you could see that. And I think you see the same thing with stretching and tissue adaptation. Yes, short-term studies, you don't see differences to muscle stiffness when measured, but you do see increases in range of motion. And the interpretation of that often came back to, well, what you're getting there is just a better tolerance to stretch. But I don't think that really fills the gap of people who see dramatic changes in their flexibility from really long-term stretching. Like you spent your whole life as a gymnast and you couldn't do the splits when you
Yeah.
were a kid. Now you can do over splits. And I
Yeah.
grant that genetics does play a huge role in mobility and flexibility, but I still do think you can see tissue adaptations. I don't think increase in tolerance explains all of those drastic changes.
Yeah, I would agree with that.
Uh,
Also, it might be different if we look at kids because kids are way more malleable
yeah,
than
yeah,
adults.
yeah.
So there's that. Like, their growth plates aren't formed yet. So yeah. No,
Yeah,
I agree.
they just adapt better to everything.
Yeah.
And to go back to your point about I think we see eye to eye with this. Flexibility is not a major component of health. Um, but I think like back pain, it comes back to personal preference. Like I think strength is very important, cardiovascular health is very important when it comes to just general health outcomes, mortality, cancer, heart disease. And you could say flexibility doesn't really fit in that picture. However, you do see a lot of the same changes with resistance training and with stretching. Like you can see hypertrophy with stretching alone. You can see increases in strength with stretching alone. And it might not be the most optimal way to increase strength and hypertrophy. But if you hate resistance training and you love yoga, I think you will get health benefits from doing that.
Um, no, I agree. I just think if you look at society, like the one thing they'll say is always, "Oh, I don't stretch enough." Like whenever they come to my office, it's rare that they say I don't do enough strength training. It's extreme. Probably heard that. Like I can count them on my hand, but the amount of people that say I don't stretch enough is maybe I hear once a day.
Yeah,
So
I
I
agree.
do. Yeah. So it depends which population you're talking about, I'd say.
Yeah, and I think that was the cause of this pendulum swing. You had
Yeah.
you had in the 90s, people would place this huge emphasis on stretching for injury prevention, for health, and then studies came out to show stretching probably doesn't do much for reducing injury. It certainly doesn't do as
Yeah.
much as strength training. It's probably doesn't achieve many of the attributes that help you live a long, healthy life. And then the
Yeah.
pendulum swung, and people said, okay, stretching should be retired as a whatever the title of that paper was.
Yeah, but again, it's just for me, I feel like what people are usually missing is either cardio or strength,
Yeah.
in that I like to meet the exercise guidelines. So I'll have like yoga teacher. I'm like, yeah, that's great. You're active. And to be fair, the yoga teachers that I have, they look great. But I'll be like, yeah, maybe we sneak in like 2 sessions of strength training a week. We make them really short, like maybe 20 minutes, 3 times a week. You at the major muscle growth, you just do supersets. And it might not be optimal for muscle growth, but the what we need for health seems to plateau quite quick. So it's like you're probably getting a significant portion of the maximum health benefits by just doing these short periods, like 2, 3 times a week for strength training. And so there's that.
Yeah, yeah, I fully agree with that. I want to talk to you a little bit about manual therapy. Um,
Yeah.
so manual therapy is pretty contentious online. Some people hate it, some people love it. And I think you're somewhere in the middle. You do see value in manual therapy at times, but there seems to be a lot of confusion about what manual therapy can do. So I've often heard from physios, and we certainly learnt this um, when we went through university, was feel somebody's back, palpate somebody's back, and see if you can feel stiffness at a particular joint, and then we're going to
Yeah.
do mobilizations or do manual therapy to rectify that. Are those statements true? Can physios feel stiffness in joints?
So I'll do this quick. I have a YouTube video about this. I think it's physio reacts to like the subluxation theory or something where I go all over why this biomedical reasoning regarding manual therapy is problematic
Yep.
with all the data provided. But if I have to start with this part, um, I believe like one form of palpation that's the most famous is palpating for trigger points. And we have this Wolf 1992 paper, which literally tests travel. It was either Travel or Simmons, like one of the creators of this concept, which I believe they were like one of them was the doctor of like John F. Kennedy. That's how they got famous or something.
Yep.
Um, so they were amongst the like one of the few people tested in that study, and they had people, I believe, that had confirmed trigger points, so-called trigger points, and people that were pain-free and people that had pain but no trigger point. Like they had the three combinations that were possible, and basically they weren't able. They were worse than chance at finding who had the trigger points. But the nuance is that the patients were not allowed to talk. So the point is, we're not feeling something physical. Can you feel something that's sore on someone? Sure. Does that soreness correlate directly with some stiffness? Probably not, or not always. People in general that have pain are more stiff, but I don't think it's like specific, like, okay, it's that point per se.
Yeah.
It's just you probably have more muscle tension because you're cramped up, like a protective stiffness, if that makes sense. Um, and then you have all these papers. You have like my favorite paper about manual therapy is the Tolberg 1998 paper, where they had people palpate the sacrum. There's this test where you put your hand on the back of the sacrum. You check how the person bends, like how they're moving, check if it's rotating right or not, which I've talked about this before, but like the test for sacrum, like they don't even make sense based on the precision of her hands. Like if you look at like studies reading, like looking at how precise the touch discrimination is in her hands, and you look at the movement of the sacrum, it's like the margin of error is as big as the how much the sacrum moves. So the analogy I use, it's like measuring like something that's in the increments of millimeters with a ruler that's in centimeters. You
Yep.
can't really do that precisely. So it's kind of absurd to think that we can do that. Anyways, in that paper, they had the therapists come, like a few therapists that were experienced. They tested the sacrum. They were like, okay, yeah, your sacrum is moving wrong. Then they had them do the manip. And then they said, is it corrected? And then they all said, yes, I corrected it. It's fine now. But what they also did is before and after they had stereographic imaging. I believe it's called Röntgen stereo gammametry or something. It's like a very specific form of X-ray, I believe, and or imaging at least, precise to like the millimeter. And they were like, yeah, there's absolutely no difference pre and post. But all these therapists were convinced that it was better. The clients were like, yeah, it's better. Um, so it's really hard to explain to people because they feel like they're getting gaslit. It's like it's no, I'm not the one doing the gaslighting. It's the therapist doing it to themselves as a group, and the clients experiencing like a either placebo or a contextual effect. Like they're like, yeah, someone, human touch feels awesome, but it doesn't mean that it's because your sacrum was out or that we replaced the joints back.
Yeah.
So it's extremely hard to explain that to patients because a lot of people will feel invalidated, and I will say I'm not the best at explaining that to patients. And have patients just say like, oh, I don't like straight up say just, well, I don't believe that. It's like, okay, like I don't know what to say about that. Like, cool. Um, yeah, so it's I don't know, it's deeply ingrained in culture, so it's kind of a like a rabbit hole, but most studies show that. So if you look at the Bialowski, I believe it was in 2016. Well, he did a paper first in 2006. He's like, okay, if we look at the mechanism data on manual therapy, we have basically no data that suggests that it's biomechanical, despite that being what's taught in the curriculum currently. And we have a bunch of emerging data that's mostly neurophysiological. So effects where you're not actually moving it's not the joint changing position, it's not the tissue changing stiffness, it's not a physical effect. It's more like effects like temperature of the skin changing, conductance, activation of like the nerves around, like more like again, neurological effects and effects like, oh, what's the therapist wearing? Stuff like, how you
Yeah.
feel and how
Yeah.
your nervous system is activating and stuff like that. Parasympathetic and sympathetic activation, stuff like that, that is very non-specific. We have some evidence of that. And he redid the paper. He's like, okay, let's check back 10 years later. He's like, yeah, we still don't have any evidence of mechanical mechanisms, biomechanical mechanisms of manual therapy. We have so much more data on neurophysiological effects. So we
Yeah.
should definitely drop that ball and looking for that perfect paper that shows that it's like, no, it's actually mechanical and go for, yeah, it's probably I think we can conclusively say that it is neurophysiological effects
Yeah.
at this
So,
point.
so to summarize that in layman's terms,
Yeah.
manual therapy does not release your fascia. It does not realign your joints. It just feels good.
Yeah, which is good. There's value in that. It's a different reason. And the reason why this matters is because if it were mechanical, then yes, it would make sense that we treat the human body like a car. Like, yeah, you come up for your checkup, we do maintenance care and all that. But since it's neurophysiological, it's more like a feel-good effect. It would be like the equivalent of giving you cough syrup to prevent the cold. No,
Yeah.
it treats the cold. It treats the effects of like when you have pain. Like when you have pain, sometimes your body creates more tension to protect itself, and that's uncomfortable. So there's nothing wrong with getting a massage at that time because it makes you feel better, and feeling better is worthwhile. It's probably not curative. It's probably more palliative, and therefore it's not going to be preventative either. And also, I do want to show like maybe why another reason why it's deeply ingrained. People that work with their hands, they'll say, "Yeah, no, I definitely feel the tension leaving my hands." Yes, that is true. I want to validate that. If you're a massage therapist, if you're an osteo, blah, 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 or a physio, yes, you can feel the release of tension be like in your hands. Erickson Kromer had a paper on this in 2015. So he had people massage, I believe, for 7 minutes. He had them massage the muscles of people. And then he measured the tension before and after. And it showed, yes, the tension was lower after. But if you just tell people to stay on the table for 3 minutes, the tension was back completely to normal. So the point is, yes, there is a mechanical change short term, but it's not long lasting. That doesn't mean massage only lasts 3 minutes. If you've ever had a massage, you feel good for a long time. It's just, it probably has more to do with the context of the massage, the fact you've been touched, the nervous system, all that. It's not because we're literally changing it's like we're not pizza dough. Okay, like that's just, or we're not clay. That's not how it works.
Yeah.
You have a nervous system that's way more there. It's made to keep your body in homeostasis, same temperature, same tension, most likely. So that's not how it works. But yeah,
Yeah.
it doesn't mean massage doesn't help.
Yeah, yeah. The other thing is we have very robust tissues holding our body together. You require a lot more force to change those tissues than you can generate with your hands. And that's why, surgeons need things like scalpels to release
Yeah.
fascia. If you could do that with your hands, you probably wouldn't need to have a lot of the surgeries that are done.
Oh yeah, for sure.
I want to come back to the idea of imbalances. Now, my opinion is that most imbalances don't really matter. And this idea of structural balance is nebulous at best. And there's so much variation. It's very difficult to make hard claims like you should have this particular ratio of internal to external rotation, or you should have this particular quad to hamstring ratio. And I liken that to saying everybody with a certain height should have a certain shoe size. It's just not true. There's variation. People can be healthy being 6 foot with a size 9 or a size 11 foot. Do you think imbalances play a role in injury? Or do you think when the studies show an imbalance playing a role in injury, it's more related to a relative weakness? Because we do know that tissue capacity mechanistically
Yeah.
can influence your injury risk. If you have very strong, resilient tissues, you're less likely to get injured than if that tissue is weaker. So do you think, do you think imbalances on their own are a risk factor for injuries, or do you think it's more related to a relative weakness in a tissue?
I do want to caveat what you said though. I think yes, the stronger tissues are usually more resilient to injury,
Yep.
but it doesn't mean they're less likely to be injured because in general, if you look
They
at
can
pro
generate more
athletes, they get
force.
injured
Yep.
more because
Yep.
they're able to generate more force and they're exposed to more load than just a normal
Yes.
person. So yeah, provided that load is maintained the same, yes, having stronger tissue in general seems to reduce injury. Yeah, I agree. The way you phrase it is exactly what I say is that in general, when we see that imbalance matter, like what we call like limb symmetry index for the quad, it's just a proxy for like your the body's strength relative to your body weight.
Yep.
So let's say, because we have papers that compare this, we have the Timmons paper from 2015. This is a post I did a while ago. When there is a side-to-side difference that predicts the injury, it's not as predictive as the strength to body weight ratio. So it's more an indication that either you've been injured before, so that joint became disused, so it's a little bit weaker, and maybe has a history of previous injury, or it's just that it's not as strong as it could be compared to your body weight. So yeah, there's the Timon and all 2016 prospective cohort study on this, and there's the Markovich 2020 paper, also a prospective cohort that shows the same. So if you compare the two head to head, strength to body weight ratio is more predictive than side to side, likely because the causal variable is basically your ability to resist force compared to your weight. Um, and absolute strength, I believe in this paper, or one of these paper, was not necessarily predictive because again, you have to compare it to how heavy you are, right? If you can deadlift your 7 times your body weight, it's probably more protective of injury than being able to like do like 1 time your body weight, but you're 7 times heavier.
Yeah. Yeah.
You know what I mean?
Yep.
Yeah,
Yeah.
good point. That's exactly how I'd phrase it.
That makes perfect sense. So you don't focus much on push to pull ratios, hamstrings to quad ratios. Focus more on just general strength.
Yeah, sometimes I calculate the body weight ratio when that's available. So there's some data for the groin, there's some data from the knee. So I sometimes use those,
Yeah. Do you ever
or I
do you ever
look at
look at
reference values.
do you ever look at structural balance ratios? I know it's very hot in the ATG community.
What
Your
do you mean
push
by that?
so your push to pull ratios. You look at somebody's. I understand you would look at somebody's pushing strength and you might scale that to their body weight. But do you ever look at a ratio of, say, internal to external rotation, or do you just look at those separately?
Uh, Separately.
Yeah.
I don't
I'm
believe
the
there's any
same. I
good
don't think they're
data.
important.
Yeah. I don't. Sometimes I look at, and also for those, there's the body weight to strength ratio, the strength to body weight ratio that's available for shoulder dislocations. I believe it's data in water polo. So I'd
Yeah.
rather use that. Like, I don't, yeah,
Yeah.
it doesn't make
I,
sense.
I
And
think,
external rotation will never be equal. I don't know if that's what they're striving for. External rotation will always be weaker than internal rotation unless
yeah.
you are
But
free.
I think they have this idea that it should be, your internal rotation should be X amount of your external rotation. But I don't think I think to steelman their argument, they're not proposing that it should be 1-to-1, but they're proposing that there is a ratio that should be there. However,
Hmm.
that ratio is just made up. Um,
Yeah, I'd like to see where it's from.
yeah, so
Ask Ben. We're in
I'll
contact very often.
I'll give you a bit of a background on this. This is my understanding of how this structural balance concept came to be. There was a famous exercise physiologist named Charles Poliquin, trained a lot of Olympic
Oh,
athletes, who proposed structural balance ratios based on the athletes that he trained. What he did was he took a group of his elite athletes, he looked at their ratios for certain lifts, such as close grip bench press to shoulder external rotation, did that systematically with certain tempos and rep ranges, and then said, okay, my great athletes have these ratios, and therefore this is what the ratio should be. However, I don't know how he reached that conclusion. If he just took the average of all of his athletes and found this one ratio and said everybody should aim for that ratio, it seems to be that way. But I see so many flaws in using that method. So it just to give this example, if you took the push to pull ratios of rock climbers and of breakdancers, you would get extremely different outcomes. Breakdancers can only push, they can't pull from the ground. So there's a lot of very strong breakdancers who can hold a full planche, do handstand push-ups, but can't do a chin-up or can only do a few chin-ups. And I would suspect the opposite is true in rock climbers. And if you had 2-to-1 push to pull in breakdancers and 1-to-2 push to pull in rock climbers, and you took the average and said everyone should have a 1-to-1 ratio, you suck at everything. Well, you suck at breakdancing and rock climbing. It's not good for either of those. And I feel like that's what he did. So from that, he published these results. You can find them on T Nation. And I think the ATG crowd look up to Poliquin a lot and have kind of just kept promoting that message. I'll share this screen with you to show you Charles Poliquin's proposed ratios. So this is from a website, Peter Roberts Coaching. I don't know who this guy is, but you can find these values a lot of places on the internet. So he proposes if your close grip bench press is your starting value, then your 8 RM seated dumbbell external rotation should be 9.8% of that. And your trap 3 raise should be 10.6%. And to me, it seems like he has just, made some incorrect
yeah.
interpretations.
Also, it doesn't make any sense at all because it completely obfuscate like anthropometric variables. So, like, let's say the bench press and then your deadlift. It's like my just like no training at all. I can like probably, I can squat, I don't know, like 1.5 times my body weight. My bench is atrocious, but like my deadlift, I can, how much do I weigh? Hang on. Yeah, easily, training, I can deadlift like twice my body weight. And it's just because I have very long arms. So obviously my bench is going to suffer. So this is like imagining, yeah, if you're the Vitruvian man, where like your ape index is 0, like your arms, your wingspan is exactly your height, maybe. But then there's a vast array of people, especially in athletes, where that's not the case. You do that with basketball players, which are known to have long legs and long arms, and that's not going to work at all.
Yeah,
You do that in climbers, it's going to be horrible.
exactly. And
Um,
this is what makes, like, variation is beautiful, and this is what makes people good at different things. This is
yeah,
why we have basketball players and we have rock climbers, and
yeah,
they don't all look the same. You see different attributes in different sports. And this is based on this idea like everybody should be a certain way, and they shouldn't. If you want very different
yeah,
attributes for gymnastics, for horse riding, for basketball, for soccer, if you had a lot of people try to achieve these attributes, like a lot of your strength is genetic. Your moment arms, your internal moment arms, are going to be determined by where your muscle inserts on your bone. So where your tendon
yeah,
attaches, and that can account for a great deal of variation in strength. And if you have great insertions for a particular movement and you have terrible insertions for another movement, genetically, you might just be great at pushing and terrible at pulling. And no matter how much training you do, you'll really struggle to hit those ratios that he's proposing.
think if you look at it, yeah, methodology, you'll see that Charles Poliquin is not the most self-doubting guy. He was extremely confident. Like his supplements, he's like, yeah, this is the mechanism. Like, biochemistry is barely a thing, but yeah, I'm 100% sure this is what you do. You would say with like, he was extremely like he was making some weird claims. Like he was basically practicing medicine with like nonsense supplements. So as to me, that's always like a huge red flag. So I'm not saying he wasn't useful. I think his paradigm shift was quite useful. It's just that I don't think that the way he acquired those ratios was done in a very scientific way.
Yeah, I agree with that. I had a friend who
Yeah.
took a bunch of Poliquin courses, and after one of the courses, he came to breakdancing training, and he was like, "Hey, you shouldn't stretch." I was like, "Why?" He said, "Oh, stretching makes your muscles hypoxic, and then that will lead to scar tissue being laid down, and it'll make you less flexible." And just at the time, like as a 15-year-old kid, I was like, "That sounds fucking stupid." But one criticism I often get every time I post about structural balance and I say, here's Charles Poliquin's ratios, and I don't think they're very scientific. I think he basically just made these numbers up and that they're no more useful than any other numbers. A lot of people say, well, that guy trained 400 Olympic athletes, so he clearly knew what he was doing. But Joel Seedman's trained a bunch of a
Yeah.
bunch of elite athletes, and he very clearly says a lot of things, especially with his 90-degree angles that conflict with the research and the consensus among experts.
Yeah, and it's such a dumb claim. It's a question. Like I have so many people that follow me that are either Olympic athletes or they train exclusively like in NFL athletes, and they'll ask me advice. It's just I don't. You and I think we're not super bolsters. Like we don't scream it on the roofs. It's like you remember that debate with Greg Lehman and Andrew Locke? It was like a clash of cultures,
Yeah,
where it's like, Greg Lehman didn't even mention it during the debate. He's like, "Who have you trained? Who have you done it?" He's like, "You literally trained the woman that has the most that has the most world records in powerlifting in history." And he just didn't even mention it because it's like he's not a douchebag. I'm not saying you're a douchebag if you mention your athletes. It's just to me, I just don't do that, and I think you don't do that because as a physio,
yeah,
we have like very strict patient confidentiality guidelines. And it's just me. I was raised in like a healthcare family. Like I was raised in a hospital, and it's not something that you see where you parade around your patients. Might be
yeah,
good for business, but it makes me feel icky. It's just a me thing. I'm not saying you're bad if you do it. You should get that dollar. It's just I don't like to do it that way. I feel like I have other ways of attracting attention, and I think you do as well. So
yeah.
I don't know.
And your ideas should stand strong on their own, regardless of who you
Yeah,
trained or what you look like, you know. And like you said
yeah,
earlier, you now like to attack ideas rather than the person. And I think that's how it always should be when you're trying to get to the truth of claims around health and fitness, nutrition.
yeah. And I will say also, like athletes are not like the best. They're not the best gauge of that something's good or evidence based because like they have an infinite amount of money often. Like Novak Djokovic, he believes in a bunch of nonsense, but he's like so rich. He's got like hundreds of millions of dollars. What does it matter if he gets a useless session for like $100?
Yeah.
It's
Whereas
like a buck drop in the ocean.
that struggling mom trying to raise three
Yeah.
kids, work two jobs, that
Yeah.
one physiotherapy visit that costs, $100 will will have a meaningful impact on her finances for the week.
Yeah, so that's why again, using pro athletes, every this was like one of the first Olympics where we didn't see like a new fad in nonsense. Before it was like K-tape. Well, after that it was cupping. And again, we're not saying, well,
This year
cupping
we
could help,
hey, we got ray
surprisingly,
gun.
but huh?
We got ray gun
Oh,
this
we got
year.
Rega. Yeah, that's true. Yeah. But yeah, K-tape I'd say is pretty much nonsense. Cupping could help. It's just a form of manual therapy. K-tape I don't believe does anything. But yeah, whatever. That's another story.
I wanted to talk to you about the idea of placebo and to use that as a segue into the idea of nocebo. Could you explain what placebo is and what nocebo is, and why you try to debunk a lot of misinformation online?
Placebo is basically that there is an effect based on the ex caused purely by the expectation of an effect, whether the effect is real or not. So you think it's going to work, so there is some form that it works. It's usually small and very short lasting. And nocebo is the opposite. You believe in that there could be side effects that are nefarious. So you experience nefarious side effects despite the drug or treatment being actually inert. Like it could be a sugar pill and you're like, oh, I have a headache from the pill. It's just, yeah, that's not what's going on, buddy. Um, yeah, so it's just, if we have bad beliefs, it can have harmful effects. That's for one. I'd say it's more like the nocebo effect, I'd say is bigger than the placebo effect because in general, negative beliefs, first of all, are harder to get rid of because humans are motivated by fear. Loss aversion is like a very simple concept in psychology. There's that. But also because um, like imagine how hard you would fight someone who steals $20 from her pocket versus how hard would you work for $20. Like I wouldn't fight in a dark alley for $20, but if someone stole $20, I might. So there's that. So it's kind of harder to get rid of. And also the nocebo effect kind of predicts behavior. So you might go like if you go to a massage therapist because it feels good, and let's say in that case it's just a placebo effect. You feel like your cold is getting better. It's not that harmful. Again, I'm not saying massage is placebo. I'm just saying in that case it would be because the massage doesn't treat the common cold. Um, but the nocebo effect would be more like stuff like, oh, I shouldn't be doing this because I shouldn't work out because it's gonna make me short. I shouldn't do this, and it's gonna make you short. It's just that these negative beliefs will like restrict something that's already restricted in a lot of the populations. Like the majority, like I think it's 75%, only 25% or so of the population meets the activity best practice guidelines. So they do enough strength training and enough cardiovascular exercise in North America. So they already have all these reasons not to exercise, and you're giving them more. So I feel like there's like more harm from the nocebo effect than potential benefits from the placebo effect. Because again, placebo effect is usually short and a small effect. I believe we have the Streicher study on low back pain, studies involving placebo arms in a study, and in general, again, it's not something to hang your hat off on. It's like, yeah, okay, there's small effects when you measure it objectively. Yeah, so I believe that's why I'm so hung up on it. And also like I had like this formative experience in one of my first placement. I worked in oncology at a hospital in one of my clinical rotations. And I saw a girl that was like almost my age, and she had gone to Mexico for alternative treatment for what the doctors were saying was a very treatable cancer. And then she had to come back because she was like the cancer metastasized. And I had to move. My goal was we had to move this patient and get her up, and it was so bad. She had so much metastasis down her spine that when we just had to sit her up for the first time in a few days, I could feel her bone, like her fractured spine in my arms, like going, and
Yeah.
it's just like it sucked because it's like this girl, like, in another life, we could have just been, I don't know, dating or something because we were the same age pretty much. She just got swindled by some charlatan in Mexico and who promised like basically these like magic beans, and that person is dead because of that. And there's data to show this, like people will forego Western medicine or conventional medicine in favor of um like alternative treatment only. The rate of survivals for cancer are way worse. So it's like you're better off. There's a reason why mainstream medicine is a thing. It's just because it tends to work. In general, yes, there are side effects, but they're usually outweigh the risks. The benefits are already usually bigger than the risks. So
I have
yeah, I guess there's a personal aspect to that.
yeah, I have a story my mum told me. So my mum's a family doctor, and
Yeah.
she said when she was going through medical school, one of her friends was diagnosed with cancer. It would have been a relatively simple cancer to treat with surgery. But somebody told her to eat apricot kernels instead because they contain a substance that produces cyanide and that will kill the cancer. She ended up dying because this cancer metastasized, and
Yeah.
she ended up getting, I believe she ended up getting chemotherapy or radiotherapy anyway as a palliative comfort measure to treat her for the pain she was in. So yeah, I think it goes to show you that bad ideas can have serious negative consequences.
Yeah, I agree. I'd say the most common thing that I see is people who they'll be like, oh, they have these like recurrent pains, and they're like, yeah, I have to go to like osteo or massage or physio or chiro, every so often, like every month or something, or a few times every month. Otherwise, the pain comes back. And it's like, I don't think we have data and the mechanisms that we know how by which we think manual therapy works, it makes really improbable that that's actually what's keeping the pain away. Again, when you have pain, these treatments, these passive treatments are extremely worthwhile. Like it's fun to have pain go away for a little bit. That's great. But
Yeah.
it probably is not preventative. So for me, it's like the most common thing I see is just a waste of resources. Like I never like I don't bother anymore telling them like it probably because it's just you lose the relationship with the patient because they have these deep ingrained beliefs and it's really hard to modify someone's belief unless you see them for a very long time. And in
Yeah.
my experience, I won't address them unless they ask me. That's one of the reasons that as much as like fourth or fifth opinions are really tough to have because they're not like low hanging fruit. They're difficult cases with the
Yeah.
ones I see online. I will say they're more receptive to alternative explanation because they've seen that these magic wands that people pretend to wave they're not necessarily magic. So they're more open to maybe a grounded scientific explanation for why pain keeps happening, despite them trying all these things.
Yeah. That's a huge problem with physiotherapy, with osteochiro, is that
Yeah,
the incentives don't align with ethical behavior. And that's something I really like about you. You seem to treat people ethically. At
I
least it
try
appears
to.
that way. Just
Yeah,
just based on your content online. As you said earlier in this video, you tend to see people, 1 to 3 times, and you can generally get good results with that. I think one of the biggest problems with physiotherapy is that the incentives aren't aligned with ethical behavior. So the incentive for a physiotherapist is to have clients come back. And if you work in a private practice, there is often this
yeah,
incentive to treat patients more than you have to, or more than would be ethical, because the practice wants to make more money. And as a
yeah.
result, you have a lot of physios saying, oh, you need to come back, when really you could just give them a plan that they could comfortably do from home, and they can come back when they need to.
Yeah, I agree. And I think it's one thing I find really annoying with the conversations online. Like, we're still talking about manual therapy versus exercise, like as if one is better than the other. The effects are probably similar. It's just the exercise you can do at home. And that's one thing that's really been frustrating to me. It's just I feel like it's like a smokescreen that obfuscates the real issues. Um,
Yeah.
like the same way that you see, like if you look at the American like landscape, whatever you think about trans people, you need to admit that there's it's like 90% of the news, and a lot of people have never met a trans person. So it's like
Yeah.
whether you're for or against, it's just that they don't want to address like the economic issues behind all of this, and it's just like a smokescreen. I feel the same about the manual therapy versus exercise debates and all this stuff and physios being like, oh, I'm better than this, I'm better than that, blah, blah, blah. Manual therapy is the greatest, exercise is the greatest. They
Yeah.
never talk about, and whenever we have this conversation, I always say the same thing. It's like, yeah, well, what about cost? And they never talk about cost because it's bad for the bottom line. It's an extremely uncomfortable conversation for physios to have because they don't realize. I think it's easier for you and I to have this because we're kind of a little bit outside the system in some
Yeah.
degree. Like I'm self-employed, you're self-employed, but it's just these there's if we treat it ethically, well, not ethically, but how most studies suggest we need to do, which is like mostly like a minimal and supervision approach
Yep.
and not like two, three, or even one visit a week, which I never do. I usually do like a visit maybe after 2 weeks and maybe after a month with my in-person patients. And with my fourth,
Yep.
fifth opinion, it's usually monthly visits, and even longer sometimes. Um, this model is not sustainable for the way the clinics are set up. There's way too many physios for that.
Definitely.
Right now,
You'd have
yeah.
much fewer physios.
Yeah, I
Yeah.
did a calculation once based on like how often people reported seeing people, and I was like, yeah, I see my patients 12 times less than the average physio. Like, can
Yeah.
you imagine if people all treated like me? There would be way too many physio. And right now, it's not the case. You know, it's not the case because there's not enough physio. There's wait lines for physios.
Yeah. True. True.
So there's
And
definitely
I
some overtreatment.
there's definitely overtreatment, and the current evidence suggests you can get similar results with treating people the way you do versus
Yeah.
the 12 times as much approach.
Yeah, there's so many evidence on that. There's the Chris Littlewood papers, there's the Michael Ratliff papers. They all systematically show pretty much the same thing. Um, So it's like, again, whenever I do that, the conversation ends. People don't even want to address it because it's so uncomfortable. And I don't know.
Yeah. Yeah. It's a tough one. I guess people need to make a living, but there's also a responsibility to treat people ethically. Yep.
Yeah.
Can I do, we got 4 minutes left.
Yeah.
So let's just do a really quick round. If you just tell me, do you think it's overrated or underrated?
Sure.
Uh, Therapeutic ultrasound.
Overrated. It doesn't matter whether it's turned on or off
Shockwave
in general,
therapy.
in most studies. Underrated, I'd say, in my community, because a lot it has some effect in like people that don't respond well to traditional treatment. It's quite expensive, but there is, against my bias, there's some data on it that it's good for tendons in some cases.
Motor control exercises.
Overrated, but I give them as low load resistance training.
Reassurance.
I'd say underrated. Like a lot of patients don't appreciate it, but I've personally spent like $700 on reassurance. I was in Portugal. I had like the worst pain I've ever had in my life. I thought I had appendicitis and I was stuck in an island. I was in Madeira. I was driving around trying to find a hospital that was open. I thought I was going to die, honestly. I was like, okay, I've had a good life. I'm not that sore about it. And then I went to the hospital, finally found one that was open. And it was just like, yeah, you just have like really bad gastrite. Like your stomach's has like a bug inside. They gave me reassurance. They gave me pain pill, didn't do shit, but I had reassurance. Like, yeah, you're not gonna die. You don't need surgery. Just go home and then 2 days later I was fine. But I paid like $700 for that. And
Yeah.
I'm not sore about it. And then
I,
people, that's like most of your visit and they'll be angry about it. So I think it's definitely underrated.
yeah,
That's
I
my
think
opinion.
I think reassurance is one of the most valuable things physios can do. Education, overrated, underrated.
Underrated, it pretty much beats or equates it equates like pretty much every treatment when you compare it to like multiple visits or multiple treatments. So it's pretty good. You get like 90% of the effect from just education, in my opinion.
Yeah, scraping or the Graston technique.
Overrated. It's painful bruises.
Cupping,
Uh, Mix of both, I'd say. Like it's equal to manual therapy, so overrated by its users, underrated by people who shit on it. It's just not worse than other manual therapy. It's just manual therapy that gives you a hickey, so
taping and kinesio
it's
taping.
overrated. It doesn't do shit. There's literally a meta-analysis from 2015 that says like it doesn't do anything. That's like
Great.
the title.
EMG.
DPMG, very underrated. Surface EMG doesn't do much. There's this paper by Vygotsky from, I believe, 2022, logging for a proxy for hypertrophy, and it doesn't seem EMG activity doesn't seem to predict hypertrophy because it's a measure of excitation, not like actual activation.
Great. Can you let listeners know where to find you? Where can we see and hear more from you? And if we want to consult with you, how do we go about that?
Sure. I'm at Nobullshitphysio, one word, on all platforms. You can find all my links if you want to book a consult on Instagram mostly. There's a link in my bio. I do consults internationally. If you want to see me in person, I'm only in Montreal though. Yeah, and I'd say I guess things to look up to like my series on again how urban planning is gonna impact your health and political policies. I don't know if that's redundant, but yeah, impact your health. Um, yeah, that's pretty much it. I don't think I have anything else to plug. Oh yeah, I have a podcast called the Fact Check Podcast with this guy called Elliot Sierra, which is the Rehab Cairo, and Skeptical Physio, which is Diego Hidalgo in Spain. We host a podcast where we do deep dives in like health, fitness, and weird claims. We just did a huge one on the carnivore diet and why it's probably not a great idea. And we did one on the craniosacral therapy, but we explored weird topics like that. We have one that's already shot on. We had the guy who gets on NBC and gets criticized by Tucker Carlson about the opiate crisis. That's pretty interesting because Tucker Carlson did a whole segment on him. It's this guy, doctor named Ryan Marino, and Tucker Carlson shit on him, and we gave him a chance to respond, and his response was pretty funny. Um,
Great.
yeah, so that's it.
Awesome. Thanks a lot. Thanks for your time.
Thanks for having me.
Take care.